about dissemination research and implementation science happening in our community and on our campus and beyond. And we are very excited to have a faculty speaker right here from UW-Madison today. We have Dr. Sijia Yang, who's an assistant professor in the School of Journalism and Mass Communication. Dr. Yang got his PhD in communication from the Annenberg School for Communication at the University of Pennsylvania. We will be excited to hear about his talk today, which is entitled "A Community-Engaged Approach to Develop and Disseminate PSAs Promoting COVID-19 Vaccines on Social Media, Targeting Rural Communities, Lessons Learned from the Communities Confronting COVID C3 Project." Dr. Yang will plan to speak for about 30 to 40 minutes, and he may turn off his camera to preserve his audio as he presents. And then we'll have about 15 to 25 minutes for discussion. We're really excited for everyone to be here and participate. And if you could, please mute your microphone while you're listening so that we don't get echo. If you have questions, please feel free to put them in the chat during the presentation, and during the question and answer, I will be moderating. So thank you very much for being here. And Dr. Yang, I'll let you take it away.
All right, thank you so much, Heidi, for the nice introduction. It's really my great honor to be here today, sharing some of our findings from our project named Communities Confronting COVID project. So as you can see, this is really truly a collaborative kind of project. So I want to acknowledge the very important contributions of my team members on this project, including Ran Tao, who is a PhD candidate from the School of Journalism and Mass Communication, Mahim Butter, who used to be our project manager, but now is grad student at the MPH program, Malia Jones, currently assistant professor in the Department of Community and Environmental Sociology, both Andy Garbutt and Daniel Bo. They are professors from the School of Education, and particularly the Department of Education Psychology. And we have Susan Passmore, our PI on this project, and also currently is a senior associate director for ICTR Collaborative Center for Health Equity. And I also want to acknowledge the generous funding for this project we received from CDC through a supplementary award to the University of Wisconsin-Madison Prevention Research Center. Our team members also received generous support from ICTR, from the NIH Clinical and Translational Science Award, and also some funding from Wisconsin Alumni Research Foundation as well. And for this project, we really are lucky to be able to partner with a range of both within campus and also beyond campus community partners. And it's particularly, I would love to acknowledge the very important help we got from the Southwestern Wisconsin Community Action Program, who really play an instrumental role for help us with this project. So for today, I'd love to begin with an overview about the problem that we're trying to address in this project, and also some of the core components and characteristics we think are unique to our project, and we think are some lessons that are worthwhile sharing with you all, and hopefully beyond our community and for other people and groups interested in promoting vaccine in rural communities. And then I'm going to love to share some data and some findings, the research results from two parallel experiments. So one is a national survey-based experiment, and the second one is a parallel field experiment that we've done on Facebook. So we think methodologically using this approaches through this kind of parallel experiments, one a more kind of traditional online survey-based experiment, the second like using some of the Facebook and other social media platforms, that kind of seem to represent an interesting, I think, useful methodological approach for people to consider as well. And then we'll end with some discussion about some lessons and insights we got from this project. We'd love to share with you all, and then open for Q&As. All right, so the core issue we're trying to address here really is the rural-urban disparity in COVID vaccination and beyond. Despite a growing availability of efficacious COVID-19 vaccines in many rural communities, the rural-urban gap in this COVID vaccine primary series completion has actually widened more than twofold between 2021 and January 2022. And the receipt of boosters or additional doses were also similarly low in rural counties, both nationally and also in Wisconsin. And this persistent COVID-19 vaccine hesitancy in rural communities really prevents this underserved group already from acquiring this population immunity necessary for timely economic recovery and restoration of everyday life. So this also threatens to worsen pre-pandemic rural-urban disparities in other vaccination rates, and including influenza vaccination and the routine pediatric immunizations. So addressing some of the barriers to vaccination in rural areas really is critical to achieving vaccine equity and also reducing COVID-related illness and death in Wisconsin and other states. So therefore, we believe there is a really urgent need to develop communication-based interventions to improve vaccine confidence, especially in rural communities. So in many rural areas, social media are among the most frequently used sources for health information, especially for people with lower health literacy. So therefore, social media and online sources, they represent important outlets for disseminating vaccine-related information among rural communities. So for example, some past studies has linked the regional differences in vaccine-related discourse on Twitter to offline vaccine uptake. So both in the cases of the 2018-2019 seasonal influenza and also COVID-19 vaccination as well. So the problem is that to some extent, the public health community has lost a big part of social media to misinformation and also discourses of vaccine refusal. The combination of automated bot accounts, some of you may already heard about, different kind of recommendation algorithms on social media, and a very active and vocal cluster of anti-vaccine advocacy groups has made it much easier than before to disseminate groundless misinformation across multiple social media platforms. So these coordinated anti-vaccine campaigns have created a distorted presentation of the scientific consensus and also majority public opinions regarding vaccine safety and efficacy. So unsurprisingly, during the pandemic, geographically aggregated presence of social media misinformation against COVID-19 vaccines. They are aggregated at a state level, as you can see from this figure right here. They predict actually lower uptake rates offline and also higher self-reported hesitancy through self-reported surveys. So we need effective counter misinformation and also counter refusal communication campaigns to reverse this trend and to some degree to reclaim this lost ground on social media. So what are some of the barriers then to effective vaccine promotion communication campaigns? So one of the major barriers we believe is the trust gap. In rural communities, feelings of distrust of government, urban centers, and the media, and also the media continue to escalate. And these are traditionally the core messengers in many communication-based campaigns. So we believe that simply repeating, for example, over and over again that CDC recommends vaccination, that kind of message wouldn't really resonate with people in rural areas. So that kind of motivated us to turn to local clinicians and nurses as potential messengers for the campaign, as they remain the most trusted sources of health information, including vaccination in rural communities. So this is supported by multiple national surveys, as well as one of our own survey to patients served by the federally qualified health centers in Wisconsin. So if we agree that local clinicians and nurses, they can potentially really be persuasive and powerful messengers. So next question to us is, what should be the message really in these campaigns? For example, should we try to repeat those hard sciences, translate them into a layperson's language, statistics, numbers to present, or should we try to present like personal stories and testimonials from our local champions, right? So our approach, the C3 campaign, really emphasizes the power of personal stories and testimonials related to pandemic and also the COVID-19 vaccination. So there's a really long literature in the domain of health message design and persuasion. And from that line literature, we know that stories and the testimonials, they can be very powerful devices to motivate health behavior changes, particularly through activating different kinds of emotions. And the research on COVID-19 pro-vaccine message design and testing, although they have already, there's a kind of emerging literature have examined a variety of message features. For example, they've shown the persuasiveness of messages that emphasize health benefits to oneself, different kind of loss or gain frames, and some kind of pro-vaccine social normative kind of influences, among other features that be examined. However, it still remains today that a limited research has tried to look at the potential effectiveness of deploying personal stories and testimonials as a way to increase message persuasiveness and also the likelihood of activating the social route for influence. So that we mean by social retransmission. And our study trying to fill this gap in the literature. I will explain what we mean by social diffusion in a minute. So beyond healthcare professionals, we also trying to recruit community leaders to activate for vaccines. So we took a highly localized approach to identifying trusted local champions who have standing in a very specific rural community, and who we're trying to target, and hopefully they could help us to advocate for the vaccines. So the public health efforts sort of borrows on a social capital and a network of individual champions who can directly relate to the social, economic, political, religious, and historical context of the community, and can hopefully create trusted connections with other people, with other community members. And we collaborated with our really wonderful community partner, the Southwestern Wisconsin Community Action Program, to help us identify these local champions in rural southwestern Wisconsin. And we also used a kind of a localized, geo-targeted approach to disseminate our campaign messages on social media. So in here, we're trying to leverage some existing ad promotion functions on Facebook and Twitter that allow us to directly specify the targeted rural counties. So this ad promotion mechanism has been routinely used in marketing and advertising. So we believe that there's no reason we cannot leverage the same system to help us disseminate pro-vaccine messages. And before I sort of move on to talk about the specifics of data and findings, I would love to emphasize that the C3 project really is a multifaceted campaign and project. And it has many different other kind of components. For example, we have tried to coordinate with many kind of partners to distribute our resources. We also coordinate with community health workers such as Sean, our really great folk, and help us quite a lot to disseminate our messages in the local communities. So there are many different kind of components. So in this presentation, though, I will focus more on the message development process and present some, again, experimental data to show the effectiveness of the C3 campaign messages. That will be the focus for my part today. In terms of the key outcomes, our approach emphasizes not only message persuasiveness, which is usually the target in many health communication campaigns. So by persuasiveness in here, we mean that whether or not our message can actually increase message recipients, at least their vaccine acceptance measured through intentions. But also here, beyond the persuasion, we're also trying to measure and evaluate our message's effects on motivating a recipient to share through their online or offline social networks. So this is what we call social diversion, such as through discussing or sharing the message with others, or even to go directly promote the vaccines to their own social contacts. So this social route, this social diffusion channel, we believe that it represents a very important or the alternative kind of channel for communication campaign to produce population level impacts, other than this intrapersonal persuasion process. It plays a very important role on social media in particular, because the overall campaign reach, right? How many people a campaign can reach online, it really is a function of this accumulated shares along this message diffusion chain, right? Which will hinges again upon each message recipients, their likelihood likelihood to retransmit, to share this message to their to other social media friends. Also, when a message recipient, when they're motivated to speak up and in ideal situation, advocated for vaccines, their influences on their still hesitating close contacts can potentially counteract the negative impacts from exposure to anti-vaccine messaging, right? We know this personal influence can really help diffuse pro-vaccine messages throughout this social network. And that's why we're kind of focusing on both of these outcomes. In terms of the actual data I'm trying to present today, as I mentioned, there are two parallel studies. One is through a national online survey-based experiment, and the second is through the Facebook field experiment. In the survey-based experiment, we trying to measure self-reported intentions. For example, whether or not a person, if they're unvaccinated, is willing to take the recommended primary series of the vaccines. If they are already vaccinated, whether or not they're willing to take boosters. And for social diffusion, we measured their intentions for sharing, commenting, discussing the messages with others, and also importantly, their willingness for advocate this vaccine to their still hesitating social context, which we call social intervention in this case. The Facebook field experiment, we are trying to go beyond self-report measures and actually trying to gather data on behavioral cues. So this is the overall campaign reach, right? That our campaign by different kind of message conditions have created on Facebook. And it's going to be a combination of, again, people's willingness for social diffusion, sharing message online, but also plus the Facebook's internal algorithmic kind of amplification that's built into their system. We're trying to do comparisons between different types of messages and trying to see which one is likely to generate the largest amount of campaign reach. So in terms of the study design, we are taking a factorial design, so we'll get into the other part in a minute, but here I would love to mention that the primary factor we're trying to focus here are different message conditions. So here from the C3 campaign, we have first condition that are messages featuring local clinicians or nurses, and importantly, their personal stories and testimonials, right? How about the experiences with the pandemic and what is their decision-making process look like when they decide to take the vaccine. And the second, we have community leaders as the featured messengers in the C3 campaign PSAs, and also plus their personal stories. So two types of messages from the C3 campaign. And to help us benchmark the performance of our messages, we also selected a set of control messages from the simultaneously ongoing campaign from the state. So this is designed by DHS, featuring healthcare professionals, about doctors and clinicians for most part, about their kind of advocacy for the vaccine, although importantly, without talking a lot about their personal stories or testimonials. So these are the three important message conditions in our design. Now, next, I would love to show you just quickly some example of the message. Let me know if they can't play out on Zoom. Sorry, right here. Oh, okay. So I might have some, all right. So I might have some issues actually play the messages, play the videos as here. Okay, I'm happy to share I'm happy to post the link to our website where you can actually find all these message videos that we have created, those PSAs we have created as part of the campaign. But again, theoretically, the key distinction and how they are different from each other are listed here. Sorry about the technical issues here. And then next, because there's a factorial design, so because we're trying to focus on social media campaign, we think that another important feature or characteristic about social media is the presence of this user-contributed comments, right? As we see on social media posts, whether or not it's a Facebook post, it's a YouTube video, or it's a tweet, there are a lot of user-generated comments besides that. So we're kind of thinking that maybe those comments themselves might play the role of potentially further amplifying this effects of this of our campaign messages if those comments are, in general speaking, supportive of the vaccines. So here we also tested another three kind of conditions on the comments part. The first type of comments we tested is what we call gratitude expression. So these are comments that are talking about trying to express the appreciation from the efforts done by frontline healthcare workers during the pandemic. And the second type of comments, they are the gratitude expression plus some kind of persuasive attempt. So this is in addition to the message just saying in the gratitude example. This type of comments, they're also trying to motivate people to get a vaccine. For example, as a tweet listed here, they have this sentence saying that get vaccinated now, right? So in addition to the gratitude expression part. And lastly, we also have a no comments condition. So very briefly, we tested the results, but we didn't see evidence for the potential interaction effects between our core message condition and comments. So although we initially thought those comments will play an important role, but with our evidence didn't quite support that. So in this presentation, I'm going to focus on the message condition. So in our total experimental design, we have one more condition that's a questionnaire only control condition. So in total, we have 10 conditions total. But I'm trying to focus on the 3x3 structure and also collapse out the 3 comments conditions. So in the end, we're looking at the 3 conditions that differ by the message type as the core focus for the presentation later on. And here is a quick summary of the sample that we gathered. We gathered this sample, this is a national sample. We gathered it from a vendor called Lucid. And we're trying to target people living in rural areas, defined by, we asked the people list the zip codes, and then we match the zip code with the RUCA code. So we define everybody who has living in an area with a RUCA code larger or equal to 4 as we classify them as rural residents. So in total, we have 18 people in all of across our 10 conditions. But in this talk and presentation, I'm trying to focus the subset of 9 conditions and actually collapsing again those comments conditions. And in total, there are 1,362 people in total. We collect this data back in April 2022. And you can see here, in terms of the demographic distribution and importantly, vaccine status, we have a fair amount of people who are unvaccinated at this time, and we purposefully oversampled them. Roughly about half and a half split between vaccinated groups and unvaccinated groups. And also, we have slightly more women in the sample, but not by too much. And you can see the education level, whether or not they're currently parents. We have mostly of the sample is actually white people, all right? So you can see non-white is about between 10 to 14% across different conditions. And we, I think one good feature about the sample is that we have amount of representation from people who self-identify as a Republican. So you see that there's roughly about 40% across different conditions. So they're balanced in the political ideology and partisanship category, as we know that it's important to sample Republicans given the differences in vaccine acceptance between different parties. All right. So in terms of the key results, again, we're focusing on 2 different types of outcomes. The first type is outcomes related to persuasion. So here we use the different items to measure persuasion depending upon people's existing vaccination status. So for those rural residents who are at the time of the survey who were unvaccinated, we asked about their intention to get vaccinated. So the item reads that, as you may know, an FDA authorized vaccine for COVID-19 is not available for free to all adults in the US. How likely are you to get vaccinated with any of the currently approved COVID-19 vaccines? And for people who are already vaccinated, we ask them that, as you may know, the CDC recommends that all adults who have received COVID-19 vaccine get a booster dose after a certain amount of time has passed since their initial vaccination. So how likely are you to get a booster when it's recommended next time? So both of these items were measured on a 4-point scale. And also I put a descriptive stats here for your reference. As you can see, because the intention to get vaccine, we only measure the item among unvaccinated group. The overall mean is 1.7 on a 4-point scale, below the midpoint. In contrast, in terms of the booster vaccination intention is pretty high, 3.24, because we measure this item among these people who already got vaccinated. All right, so here is the key results, all right? So some letters here, the HP here standing for health providers. So these are the PSAs featuring local clinicians and nurses. CL standing for community leaders, PSAs, all right? So these are featuring local community leaders that are local business owners, popular radio station hosts, religious leaders, and so on and so forth. The control messages are the clinician messengers without talking about personal stories from the ongoing Our Docs campaign from DHS. So again, these are professionally made control messages, so they're actually pretty hard to beat. It's kind of high bar as a control condition. And what's being plotted here on these figures on the left one, it's on vaccine intention. So this is among the unvaccinated group there. And this is the post-treatment vaccination intentions. The point estimated a 95% confidence interval again represents between condition differences. You will see two color bars here. The lighter ones are the from the conditional model where we add in all the different kind of covariates that we measure in the survey. And the darker and more solid black ones, they are unconditional model without any kind of covariates. I'm trying to show you that the results, more or less, they are kind of stable and robust to different kind of model specification. And you can see the general pattern here. So from the left one, among the unvaccinated rural residents, we can see that compared with the DHS Our Doctor campaign control messages, the C3 messages featuring local clinicians and nurses and their personal stories, we see that significantly they increased these people's intention for getting vaccinated, all right? Both in both models, actually. And also importantly, even within the different types of C3 messages, we see the evidence that this health provider PSAs are actually a better in terms of increasing vaccine intentions than those ones featuring local community leaders, all right? And there was no significant difference between community leader PSAs and our control messaging. On the right-hand side panel, you will see that among those people who already got vaccinated, when we asked them about their booster intentions, we didn't see any significant differences between our C3 messages and our control messages. So this is the first cut in terms of the core persuasiveness of our messages. All right. And then moving on, here is some new data we actually just got like last week. So in the survey experiment beyond the COVID vaccine intentions, which is again the focus topic in the PSAs. But here we actually also inserted some items, asking people about their intention to get a hypothetical mRNA-based HIV vaccine from Moderna, right? So kind of curious that whether or not our PSAs, given this link, this kind of two vaccines both are using mRNA kind of technology, whether or not we might be able to see any kind of a spillover effects on this HIV kind of vaccines. So you can see from this figure, now the effects kind of become a little bit kind of smaller, the confidence interval a little bit wider, but it's kind of similar pattern. So compare with these control messages, at least in the unconditional model, you can see that the C3 messages featuring health providers actually increased, right? Not too big, but increased overall across both groups, people's intention to get this mRNA HIV vaccines. And when we're trying to separate them out by the vaccine status, which is plotted out on the right-hand figure, as you can see that the effects actually significantly larger, all right? Significantly larger among unvaccinated groups. So pretty much in parallel with what we have observed on the COVID vaccines in the previous figure, all right? So COVID vaccines here, and this is HIV vaccines. Pretty similar kind of pattern. Now, moving on to talk about social diffusion. So here we measure the three important social diffusion related outcomes. The first one is their willingness to share the messages, this video directly with someone they know. Sorry, there's a typo there. It's not sharing on social media, but actually sharing with some people they know, such as via email, direct messages, and so on and so forth. And the second one, we ask about their intention to discuss, to talk about this video with a person they know in the next few days. And both of these were measured on a 4-point scale. And importantly, we also asked about the participants, their willingness to tell other people the benefits about COVID-19 vaccines or promote the vaccine to people who haven't yet taken them. So this is, again, trying to capture these intentions for social intervention. And this one is measured on a 9-point scale, right? So previous two, 4-point scale, last one, 9-point scale. And here's a pattern of results. So if I looking at this, starting from the sharing intentions right here, as you can see that, again, it's kind of some evidence to demonstrating the impacts of the health provider PSAs. So compare with the control messages, this PSA significantly increased the people's intention to share these messages with someone they know. So in the conditional model, the p-value is close to 0.05. In the unconditional model, it's statistically significant. Again, slight kind of difference there, but the general pattern is there. And similarly, we can also observe a similar effect on motivating people's intentions for talk about these messages, talk about these campaign videos. And lastly, on the top, when it comes to social intervention intentions, which arguably is probably a more important outcome from the public health kind of perspective, then we can see that we can see a similar pattern. There's PSAs featuring health providers. Again, they outperformed both the control messages and also the community leader PSAs. And again, we didn't see significant differences between community leader PSAs and our control message. So again, this pattern is pretty similar and consistent across these two types of outcomes. All right, so this is the first set of results from our national survey-based experiment. So our basic and the preliminary kind of takeaway is that this suggests an experimental evidence for the advantages of PSAs really featuring two parts, right? So given this design, we can really make this claim that seems like the recipe, right, for success in this context is first we need to have trustable sources, and in particular those ones featuring local clinicians and nurses. And second, on the message content side, we need to feature people's personal stories and testimonials, right? And our design helps identify this necessity of including both pieces, right? Because we didn't observe a significant difference for most part between the community leaders' PSAs and our control messages. Right. So it's more effective than our doctors' videos, absent such personal stories in terms of the intention of vaccination or persuasion outcome, and also social diffusion. Yes, it's right that mostly small effects, but if you're considering the fact that many of those communication campaigns, their population level kind of impacts really is a result of repeated exposure and long-term accumulation, which led us to believe that even some significant small effects might be able to create long-term and population level impacts. Giving the chance when the messages are widely disseminated throughout this population network. Right. Okay, this set of results so far from the first study, they are all self-reported measures, right? So intentions. We have some evidence to say that from the point of view of evaluating messages, intentions actually can provide a pretty good diagnostic signal as actual behaviors. But of course, as we all want to have behavioral data if possible. So that's where we go to the second study. This is on the Facebook field experiment, right? Given the importance of considering the reach of campaign message on social media, in study 2, we took advantage of Facebook's randomized A/B testing infrastructure to carry out an online field experiment comparing, again, these 3 types PSAs in terms of total message reach among Facebook users living in rural Wisconsin. So we specified the geographic kind of units we're trying to target. We expect that the C3 PSAs, again, featuring testimonials from local clinicians and nurses, will produce the highest amount of campaign reach compared with C3 PSAs featuring non-clinician community leaders and also the control our doctors PSAs. So Facebook was chosen as the experimental platform because in the C3 campaign, utilized the sponsored ad promotion on this platform to reach and engage with rural residents in our targeted zip codes in Wisconsin. And moreover, Facebook A/B testing implements randomization to assess the cost effectiveness of different type of, in their terms, advertisements on aggregate outcomes such as cost per results and reviews, right? So Facebook doesn't quite provide user, so individual level outcomes. So here we focus on the total reach. Our unit analysis is per message in each campaign. So that's the count of unique Facebook users and viewers attributable to each PSA. reflecting a particular PSA's capacity to produce online exposure through sharing, social diffusion, and also cumulative optimization from Facebook's their own recommendation system. So in this design, in this study, we adopted a one-way, three-condition experimental design, comparing 4 C3 clinician testimonial PSAs with 4 C3 community leader PSAs, and also 2 our doctors control PSAs, absent any testimonial stories. All these PSAs are selected from the same streamlined pool as the previous study, right? So we didn't get chance to use all the created C3 messages because Facebook, their advertising infrastructure has this limitation that for each particular test or particular trial, we can only have up to 5 messages, all right, up to 5 messages. So here we created 2 unique trials essentially, and each one featuring 5 different messages spread out across the 3 message conditions, and each trial repeated them like 25 times. So in total, we have like 50 data points from this study, all right? Great, right here, and then here are the results. So given that the distribution of the outcome here is a unique number of viewers, right, attributable to each PSA messages. So it's a skewed distribution, and relatively speaking, it's a relatively small sample size because in total we have 50 data points effectively. So we performed a non-parametric test, the KW test, followed by pairwise with Cox and rank sum tests with home correction to compare the effectiveness of PS videos in each of the A/B testing trials. So the results, again, is pretty consistent. They show that in each trial is one of these 2 C3 PSAs featuring, again, testimonials from clinicians and in this case, clinicians produced significantly higher overall reach than all the other 4 PSAs. So with the pairwise comparison to the p-values, they're all significant. And none of the community leaders, again, testimonial PSAs significantly outperformed the control PSAs from our doctors campaign. So again, the evidence seems to support the importance or the effectiveness of featuring clinicians in this case as a powerful messengers in our campaign. All right. So this is in compared with study 1. This is we can arguably is a more behavioral orientation, or the behavior is more of message sharing and message viewing, not so much about people's actual uptake of the vaccines themselves. So some future replication is needed. All right, so I'd love to leave some time for discussion. So I'm trying to come to our overall discussion points. So although growing literature has really examined a variety of different message features to promote COVID vaccines and trying to address the challenge of vaccine misinformation and online discourses of refusal, few studies really actually focus on identifying effective strategies that can amplify the influences of local clinicians and nurses, right, public health professionals in social media campaigns to mitigate these growing rural and urban disparities in vaccine confidence. So this study, actually 2 studies, presented convergent evidence. One is from a national online survey-based experiment. The second is parallel Facebook A/B testing to demonstrate the feasibility and efficacy of the C3 campaign approach in terms of both improving vaccination intentions, especially among those unvaccinated rural residents, but also importantly, the potential to activate the social route for producing campaign exposure and influences. So specifically in terms of social media campaign message design, our findings highlight the power of combining 2 components. One is the trusted local healthcare professionals as a messenger, and the second is personal stories and testimonials as message enhancements. So our results show that leveraging local healthcare professionals as champions for vaccine promotion in rural communities is effective in terms of improving vaccine intentions and also in terms of intentions to share and talk about PSAs and to recommend the vaccines to others. So the threat from misinformation and general online discourses of hesitancy really tends to extend beyond the COVID vaccines to delay the vaccination for other types of preventable diseases. And I think the C3 approach that can really help local clinicians amplify their influences on social media and potentially reclaim this lost ground again in this online battlefield fighting vaccine misinformation and refusal. Obviously, our reports for the especially the first study relied upon self-reported intentions to assess the relative differences in message performance. We hope that future research can help collect some longitudinal and also behavioral data on actual vaccine uptake when it's feasible. All right, so I think that is so much I have for today. Thank you all for your attention, and really looking forward to have a discussion with you all. We'll stop sharing for now.
Thank you very much, Dr. Yang. This is so interesting and such compelling and impactful work. While I'm waiting for folks to put their questions in the chat, I have a couple of questions for you.
Sure.
Just to start, can you talk a little bit about the sampling method for the national survey and whether you were able to link people from specific communities with the media diet or the message diet?
That's really a great question. So in our national study, we used a survey company effectively. So it's called Lucid, specialized in recruiting online samples. So in this study, we particularly trying to target rural residents in different rural communities. So we did ask participants to provide their zip code, which we used again, essentially as a screening kind of criteria. So in this study, though, we have measured some of their existing media sort of consumption behaviors, like whether or not they consume CNN versus Fox News, as you can imagine, all right? However, in the data I presented, especially in the conditional model where we included different kind of covariates, that's where we included media consumption variables. We actually also included their political ideology and partisanship variables. So in some of the exploratory kind of moderation effects that we have run, we didn't see evidence that, initially we're a little bit kind of concerned that maybe this message would kind of perform worse, for example, among Republicans or people slightly more conservative, but we didn't actually see evidence of that kind of interaction effects. So it seems like across that political ideology groups and also across different kind of media consumption patterns, overall, these three messages, especially those featuring healthcare providers, seems to be effective on that persuasion and the social diffusion outcomes that we have gathered.
Thank you very much. And then there's a question in the chat about how community leaders were selected.
So that's really through the partnership with our community partner. So they basically recommend names to us, like who they think in the 3 particular southwestern Wisconsin counties they think are people who have that really strong standing in the local community. So they recommended to us, again, one still vivid example is Ron from I think he's a popular radio station host. So when we talk with other people around there, oh, everybody knows Ron, and he actually runs that kind of a shows through his radio program. He actually has some radio version PSAs as well, and we got a chance to interview them, recording their stories, then end up becoming part of our campaign. So it's that local community leaders is really through the help with from our community partner.
Thank you. Dr. Sethi, did you have a question? Were you raising your hand?
I was, and because I had trouble typing all of my thoughts in the chat because I'm excited about this question. But thank you for calling on me. Thank you for the talk, Dr. Yang. I really just appreciate it. You actually just did this work and that you're focusing on some real practical ways to improve public health and vaccine uptake. And my question is centered around clinicians who maybe not local to your area, but definitely national voices that have spread misinformation, and the extent to which credentialed individuals have sort of, how much did they compete with your campaign, and what kind of impact did they have during your study period, and maybe an enduring impact still today, because we still see clinicians who talk about ivermectin or spread misinformation about the risks of vaccination.
Right. I mean, that's really such an important question there. So I think that concern you raised or the issue you brought up, broadly speaking, will come back to the issue about trust. Like, who do people really trust, right? So in this study, I imagine there will be kind of continuing of trust. Although in this study, we're kind of focusing on, clinicians and nurses. When we find them, obviously, we're trying to identify people who are actually supportive of the vaccine and are willing to advocate for the vaccine, right? And these are people and clinicians and nurses really are serving that kind of local communities. So from our kind of perspective, we're kind of thinking, if we're kind of thinking about that as a continuum, right? From my doctors and doctors from other counties, right? Doctors of other people, there is also continuing kind of there. So I guess the takeaway would be, whenever it's possible, the more localized, the better, right? To some extent, if we're targeting, people living in Madison, would love to feature doctors, who are serving Madison, right? If we're trying to do a different part of the state, we'd love to feature doctors who are serving that state. So the more local, the more trust this seems to enjoy from participants' point of view. So, but again, as you mentioned, there are doctors who are willing to talk about either spreading misinformation or openly can oppose kind of vaccines. Those doctors do kind of exist. So we didn't get a chance to test, for example, what would happen if we show both messages, right? Show the misinformation from doctor first, then show again a pro-vaccine kind of doctors, kind of PSA. We haven't get a chance to do that kind of study, which I think would be a very interesting question for future research to tackle. But again, I think if we can find trustable doctors who people go to on a daily basis, they know them, and who are willing to advocate for vaccines, at least seems to us that we have some, also willing to add some stories. They seem to perform better than the other local community leaders we find in this case. Another possible comparison would be comparing this with, for example, politicians or different kind of government officials. That would be another potential comparison. But I think the broader issue again is the trust issue for the messengers, which I think is consistent with the issue you are bringing up as well.
There are a few questions in the chat, and I wanted to elevate Dr. Mahoney's question, since the purpose of this is we want to kind of use your communication brain to talk about how are you going to disseminate these research findings, and how can we take these findings to scale when we're using local clinicians, which sort of ties in with Dr. Liu's question about how local were the clinicians for the national survey.
Yeah, that's a really two great questions. So on the dissemination part, so as we roll out this study, so right now kind of presenting the kind of more empirical research findings, more kind of serving academic community. But throughout the kind of process, we have this opportunity to present some of the findings, for example, onto local healthcare facilities. We have run some presentation there. We're also thinking about some of our team members. I haven't done that much on that front, but some of our team members, for example, Susan and Malia, they are frequently featured on talking to journalists. They're kind of holding public-facing online sort of Zoom webinars through those kind of channels. And actually, Malia is also running the pandemic social media group. I don't know how many have seen that. Really have reached like millions of readership there, which was pretty amazing from a communication point of view. So there are, I think, a range of outlets and dissemination channels that we can consider. And I think right now we're doing this academic kind of findings, but again, we're trying to make this findings actually useful, right, to our local communities. So we already kind of run that campaign. So we have spend dollars on both Facebook and Twitter to disseminate our messages, and all those videos that I mentioned today that are public available on our website. So whoever is interested in using the stimuli, they're very welcome to use them to serve their own kind of purpose. I think the second question is about the localness in the national study, right? So again, that gets back, I think, to that question about that continuing of tailoring and the continuing of a trust. So from the national study, again, to some participants from I don't know, like a different state, they wouldn't be able to recognize the clinicians that featured in our PSAs, right? What they might be able to recognize is these are clinicians and the nurses serving rural areas. So that kind of a sense about, okay, this are doctors serving rural communities. That might be, at least from our experimental data, that seems to be strong enough to motivate people to both in terms of increasing vaccination intentions and the social diffusion outcomes as well. So that seems to be work for them. But what we haven't done, and I think a potential future study trying to tackle is, can we actually try to test how local or how tailored that needs to be, right? So can we set up a condition that's, it's a doctor that I see on a daily basis versus another doctor serving rural communities, then a doctor serving urban centers, for example, right? So can we actually see some empirical evidence whether or not a sort of finer grained tailoring would generate additional benefits? So that we don't know from this data. From this data, we can see is that some sense of rural tailoring seems to work in this case.
And then another question from Dr. Liu about the content within the personal stories from clinicians, whether it was their personal decision to get vaccinated or to get their children or families vaccinated, or whether it was about their experiences caring for folks during the pandemic.
Oh, that's really kind of a range. So we didn't quite specify, we didn't like put out a script saying that, hey, this is a script that you should like follow. We basically use a little bit more open-ended prompt, basically saying that, first we're making sure that everybody we talk to, they have taken the vaccine, they support the vaccine, they are willing to advocate that, right? So they are not people who trying to talk about spreading misinformation or refusal. That's not the target. So on condition that, on the fact that they are in favor of vaccines, we basically leave it pretty open. So saying that, tell us a little bit about your decision-making kind of processes. And people really sharing with us, in some cases, pretty touching stories, right? Some people sharing with us their loss of their partner during the pandemic before the vaccine becomes available, talking about they were hoping, if the vaccine could become available a bit sooner, they wouldn't need to lose their dear family members. You have sad stories like that. You also have stories about people sharing their kind of knowledge on how they kind of find out how this vaccine is developed and approved, trying to address some kind of doubts that, oh, this vaccine was kind of approved too soon. So many clinicians that were talking with us saying they heard about that kind of a doubt and concern from the patients. Some of them are pretty creative, like coming up with metaphors and stories and even some kind of jokes, trying to address those kind of concerns. And that's where they share with us those kind of stories as well. And some others share with us, for example, they just got a new baby during the kind of pandemic, exciting, and talking about their decision process, why they are still willing to take the vaccine even when they were pregnant back then, for example. There's a range of personal stories. We're really kind of trying to keep it open and trying to really bring out that kind of genuine voices in people.
Thank you very much. I think we have time for one last question. And Dr. Van Wormer has a question in the chat around whether or how representative the national sample was of rural populations, noting that the COVID-19 vaccination rates were higher than what we see in Wisconsin, and the political conservative rate may be lower. And also wondering if examining the intention outcomes in some key subgroups might be helpful. Could you speak to those questions?
Yeah. So first, just trying to be transparent, this is not representative of probabilistic sample. We cannot afford it, simply put that. But this is a national sample, and we tried our best trying to creating a sample and trying to match it with some of the key demographic features. So for example, I think you talked about the political partisanship. We know that it differed by different kind of ideological groups. And so in our sample, we have roughly speaking like 40% of it actually from Republican, self-identify as Republicans. So I think that it's well represented in that regard. And for the demographic features that we have collected, we didn't see evidence for severely kind of an unbalanced one. Only one thing we hope we can have done a better job is it's currently predominantly white, and so the racial and ethnic diversity is less than we would have hoped, but it's also targeting rural population, so maybe that actually matches up with the racial and ethnic distribution in rural communities. So it's national, we're trying to make it diverse, but it's not probabilistic sample. What's the second part of the question again, sorry?
Dr. Van Wormer, would you be willing to come off mute and ask your question directly? It was
Sure,
around.
sure, thank you. I was curious if it would, I know your sample is getting thin on power to carve it up too tightly, but it made me wonder if looking at some key your intention outcomes in some different subgroups, as standalone, to see if you get the same answer, meaning, was your messages more effective, say, in the conservative group or in the liberal group or different races, et cetera?
So yeah, that's a great question. So that's actually what we have done. So we explored the interaction effects. Let me try to think. Each of the demographic features we have collected, that we include gender, race, ethnicity. Race and ethnicity is probably underpowered. Gender we can do, income we tested, political ideology we tested. Across all of them, we didn't see evidence for moderation. So at least the message didn't perform worse among those groups we would otherwise have concern about. So it's more kind of across the board type of effects.
Thank you very much. This was a really engaging and interesting presentation, and has lots of implications for, I think, probably a lot of our work and how we think about compelling folks to do things that we think are improve health. Before you leave, please click on the link that I've just dropped in the chat to read, to complete a brief survey. This is a new seminar, as I mentioned at the beginning, and we really are taking your feedback to heart and trying to make the seminar better. Also, if you'd be interested in being a future dissemination research and implementation science seminar speaker, please let me know. There's also a link on our little ICTR website where you can nominate yourself or nominate a colleague. Let's please join me in giving Dr. Yang one more round of applause. Thank you very much for being here today. We had such a wonderful, such a wonderful talk. It was really lovely.
Thank you so much for the invitation opportunity. Thanks you all for staying for the whole hour.
Thank you very much. And everybody have a great weekend, and we'll see you next month for an update from Christy Bartles and Edmund Ramley on a blood pressure program that improves linkages between primary and specialty care to improve hypertension. Thanks, everyone. Have a great day.
Bye.
Bye.